Must be an oncologist. There are too many companies here. So. Can you go to the talk number 1, please? So I'm given the task to talk about the different definitions of biochemical recurrence of the various types of treatments in prostate cancer. And yes, perfect, thank you. So then I will also have some disclosures because I work with robotic companies and I have done a lot of robotic prostatectomies. And I also work with bladder cancer and reconstructive surgery, so I see some of the complications that you get from radiation because we heard the day before yesterday, I think there was very few, but I see quite a lot of complications and it's not the same thing to operate in patients that had radiation before. So it is a problem for us as surgeons. I don't think that sometimes radiation oncologists, they don't see these patients often, so they may not appreciate it, but it's actually one of the major problems for us. So the problem is then that we have different definitions, and this was always going to be like a comparison of apples and oranges. It's never going to be the same thing, whatever you do, because we don't basically have the same situation after surgery versus radiation versus focal therapy. We have already discussed difference in functional outcomes, and I'm not going to talk anything about the functional outcomes here. I'm just going to focus on oncological outcomes, and I'm going to take up some of the trials that Dr. Bossi threw in the bin the other day and have a second look at them. So most commonly used is biochemical recurrence when we compare oncological outcomes, but we have a lot of problems because we have different definitions, and I'll come back to this. After surgery, we can use positive surgical margin. Unfortunately, then, there is almost no correlation, or there is no correlation, basically, by most types of positive margin and the risk of dying from prostate cancer. And I will focus a lot of this talk about the mortality of prostate cancer. Metastatic-free survival probably is a better endpoint, but the problem is if you use it at different time points and when you compare different treatments. So if you, for instance, use 0.2 as a cutoff of the surgery and you start to look for metastasis and you wait until patient has nadir plus 2, then you will have a big difference in the number of metastatic events, basically. So if you want to use this, you have to use the same treatment time or the same time after treatment and look in both groups the same way. Otherwise, you will flaw your measurements. And then I think the best is to look at prostate cancer mortality. Problem with mortality is that very few patients die from prostate cancer, regardless of the treatment we give. And then, like the PROTECT trial, where almost no one died from prostate cancer, we have to throw it in the bin when we look at prostate cancer mortality outcomes. There's a lot of other outcomes, and it's a good study in many respects. But unfortunately, for the primary endpoint mortality, because of the selection of patients, it's pretty much useless, and there is no power to detect any difference between the groups. This is just to show you about what I've said about prostate cancer mortality and positive surgical margins. You see that small margins or large margins doesn't matter when it comes to prostate cancer mortality. This is actually published in European Urology Oncology like a year ago or something, and you see that the lower and intermediate risk group here, this is after surgery. You see there is virtually no one dying. It's only the high-risk patients where you actually have some patients that die. This was one of I mean, if PROTECT trial was a little bit unlucky, having a lot of low risk and intermediate risk, many of these would not need treatment today. The SPCG4, I was actually one of the surgeons that included into SPCG4 a long time ago. We tried to find low-risk prostate cancer patients, but unfortunately, or fortunately as it turned out, we found a lot of high-risk prostate cancer. And that is why there is a difference in the mortality in that group, in that study, because there we included more high-risk patients. There is here, you see the multifocal, so if you have multifocal, there is actually a trend here. But this is mostly driven by tumor biology. So the multifocal is always going to be the T3B, where they have large tumors, there will be positive margins in different places. So if you try to adjust for that, probably the difference is much less clear. Since PCR is so easy to measure, there is hundreds of studies published every year looking at BCR after various types of treatment for prostate cancer, and they are used to compare the treatment, even if I think most people that do research in this area would say that this is not a really good comparison. But we still use it, and there is paper like this one, for instance, where you look at the risk of a biochemical progression, and you look at a lot of different types of treatments, surgery, various types of radiation, and focal therapies and so on. And if you look at this, then surgery will not be as good, and some of the radiation treatments up here, especially if you combine with hormones, will do better. But this is unfortunately very common, but probably not a good way of looking at or try to find the difference in the efficacy of different treatments when it comes to prostate cancer. So we know that we use this almost always after surgery, PSA more than 0.2. And most of the time after radiation nowadays, I think we use the Phoenix criteria, nadir +2. And they also use this for many studies in focal therapy. Why? Because we can. It's not really sort of well shown that this is the best way of doing it. It's just one way of doing it, and it's been become the standard way of doing it. But there are problems. One is the bounce that you may have after radiation, where the PSA rises up without any correlation to the tumor. We know that, for instance, you will see, maybe if I have time to show that in the radiotherapy arm, there will be quite a lot of patients that die from prostate cancer that never, ever reaches biochemical recurrence level of PSA. And you will also see that most patients that have a biochemical recurrence after surgery and radiation will not die. It's very clear for surgery, a little bit less clear for radiation. So if you look at this is the data from Stockholm, and you see that what we find is this is very common finding then. You see that the mortality overall in cancer Pacific, this is adjusted for as a propensity matched population in Stockholm. So the mortality in prostate cancer is higher after radiation than after surgery. But the recurrence-free survival is the other way around. So these curves are actually opposites. So if you want to avoid the biochemical recurrence, you should have radiation. If you want to avoid dying from prostate cancer, you should have surgery. And if you go to high-risk prostate cancer, it's even bigger difference. So here you really see a big difference in biochemical recurrence. So clearly, radiation looks much better. But when you look at the mortality here, is 20 years follow-up or 18 years follow-up, you see that in the high-risk group, around 15% or so will actually die from prostate cancer after surgery. So there is like a mismatch between this high risk and the actual mortality curves. So a long time ago, my friend Lars Egervad, who is a uropathologist in Karolinska, came to me with this curve, and he basically showed me that you can play around with if you play around with the definition of a biochemical recurrence, you'll get very different Kaplan-Meier graphs. So here's a population of 2,000 patients that were operated. All of them had surgery for prostate cancer. 39 of them had metastasis. And then here is basically plotted then different relapse thresholds. So here is 0.2, the one we use, and here is 10. And you see that if you use 10, then it looks like a lot of them will have metastasis. If you use 0.2, much less. But if you instead look at the number of relapses, you will see that in this, only 3.6% of the patients, of the blue line, if we do a Kaplan-Meier, it will be up here, with 3% having relapses. So it's basically a game of numbers, how you plot this. Because in the end, there is exactly the same number of patients that have have the metastasis. And how we define or what PSA cutoff we use will change this completely. So this is the study that was thrown in the bin then that I did. We looked at all the Swedish prostate cancer register, where we have a lot of information on our patients. We know when they have their cancer, what type of cancer, stage, grade. We know everything about their life, basically, because in Sweden, everyone has a specific number. You can follow them in every register, so you know if they are married, if they have education, and all these things. And when we started to look at this, and then we tried to adjust for various ways, divide them into 4 risk groups, and then we looked at prostate cancer mortality, the dark blue and the dark red here. We could see that the mortality was higher after radiation. So prostate cancer mortality is higher. And it was even more pronounced in patients under 65. And we've also found another interesting finding here. This was the patient that only got hormone treatment, and we saw that patients that only got hormones, they did very, very bad. This is this is patient with T4 and N1 and M1. And this was when we published a couple of papers on this, saying that maybe there is a role for treatment of the primary tumor in aggressive prostate cancer, metastatic prostate cancer. And now we know from the STAMPEDE and from the RAM trial that was recently published, both surgery and radiation seem to actually have an effect for a patient with oligometastatic disease. Here is the difference. We looked at this, that was also thrown in the bin yesterday or the day before yesterday, looked at the mortality in the difference here. So we updated this like 1 year ago, something. You see that if you look at mortality, pretty much, this is prostate cancer mortality. Pretty much every study shows that surgery is better than radiation. So you can then have 2 different approaches here. Either you think that there is something here and there probably is a difference in the mortality, or this is just some type of methodological error, basically. I'll skip this and go to this. So the most common criticism of this is to say that this is because the prostate cancer radical prostatectomy group is much healthier than the radiation group. And in fact, as we saw the other day, mortality is lower in prostate cancer patients that go to radical prostatectomy in a control patient without prostate cancer. And why is this? This is for 2 reasons. One is that this cohort is very healthy, and the other one is that very few patients die from prostate cancer after surgery. So if you look here, this is the other cause mortality and the prostate cancer mortality in this Swedish trial then. And you see that there is a good correlation with other cause mortality. Even if we adjust for tumor and all these factors that we can adjust for, there is a strong correlation between the risk of dying. The red one is the highest comorbidity, the blue one is the lowest. And you see that, so for other cause mortality, yes, there is a difference. But for prostate cancer mortality, as soon as you adjust for tumor biology, they are the same. So the risk of dying from prostate cancer is not different, at least not in Sweden, if you have comorbidity or not, if you adjust for the tumor biology. So it's not a good explanation to say, no, they are just healthy patients, that's why they don't die from prostate cancer. Doesn't seem to be the case in Sweden. And the Swedish quality of death or prostate cancer registry and the death registry has been evaluated for prostate cancer and published about this at least 3 times. So we looked in modern data. So this is from Stockholm data now. This is what we see right now in Stockholm. We have a good situation in Stockholm. There are only 3 labs that are taking PSA samples. So all the PSAs in Stockholm, regardless if a patient has prostate cancer, comes into register where we have the data. So as long as the patients stay in the Stockholm County, which is around 2.5 million, 3 million, we get every PSA. So we have a large register of patients, and we, as I told you, then have very good information. So we looked at patients that were between 40 to 75 years at the time of diagnosis for prostate cancer. We excluded some patients, metastatic patients, and treatment with no curative intent, and the very advanced, like N1 or at the time of diagnosis then, so not N1 after surgery. And we looked at mortality. And then we did the propensity score matching of the populations, and then we looked at the mortality. And when you look at the mortality, we find the same thing as before, that the mortality is lower in radiation compared to, in surgery compared to radiation. So for us, this was the same finding as before. Here you see it again. And you see the same finding here. Biochemical recurrence is the other way around. So for biochemical recurrence, you should go for radiation. For prostate cancer mortality, you should go for surgery. So this is even bigger difference in the high-risk group, where we have a bigger difference in mortality and also a much bigger difference in biochemical recurrence. So the patient over here, they will be much happier than this patient, because someone will tell them that you have a recurrence from your cancer here. So surgery will have a problem, because we tell patients that are very unlikely to die from prostate cancer that they have a biochemical recurrence and they have a cancer. And radiation have the other problem. They don't see this, and they don't tell the patient, and they will not give any salvage treatment. The time to salvage treatment will then be shifted. So the idea with this study was to see, can we define other endpoints after radiation or surgery that you can compare them better? And the other thing is, should we give some salvage therapy earlier to patients that are radiation failures? So this the intermediate risk group is the same. Yeah, so here is the big difference then. If you look at the patient, these are patients that have a biochemical recurrence. So they are, sorry, here. So you see that after surgery, if you reach 0.2, they're divided into two risk groups, high risk and EEU, low risk. And you see that this is the risk of dying within 10 years in prostate cancer. And you see that if you have a biochemical recurrence after surgery, you have actually very low risk of dying from prostate cancer within the next 10 years. If you have a biochemical recurrence after radiation, regardless if it's low risk or high risk, you have a much higher risk of dying. So there is a mismatch at the time of a biochemical recurrence. They are not sort of biologically equivalent, in the sense that the risk of dying is much higher after the biochemical recurrence after radiation. And here, I don't know if you can, this is probably difficult to see here, but here we plot this, we divide it into three different risk groups. So this is low, intermediate, and high risk group. And this is radiation. This is only patients, so this is not all patients, this is only the ones that have a biochemical recurrence. So there are more patients up here, because there are more patients after radiation or after surgery that will have a biochemical recurrence, and much fewer patients down here. So you cannot really sort of compare this for efficacy of treatments or anything. But you can just see what happens after a recurrence, okay? And if you see here, for instance, so if you go to an intermediate risk prostate cancer patient, and that will have his recurrence after 4 years, I think, yeah, there's 9% risk of dying from prostate cancer within the next 10 years. If you do the same thing, look here, you will see that if the same thing happens after radiation, then you have 30% risk of dying within 10 years if you have a biochemical recurrence after 4 years. And if you have if you have your biochemical recurrence quickly after radiation, you have very bad outcomes. So if you have a biochemical recurrence within 2 years after radiation, you really have a high risk of dying from your prostate cancer. So then we have played around a little bit with different definitions for a recurrence. So here, for instance, this is what we're doing right now. So here you see 0.2 and nadir plus 2. Surgery is not as good as radiation when you look at this. And then we start changing. So here we changed nadir plus 1.2. You see that the black line is coming down a little bit. So this is just playing around with the curves like we discussed before. And you can see that if you change your prostate cancer definition after surgery to 0.5, they become very similar. And if you have the nadir plus 1 or 0.5 after surgery and nadir plus 1.2, then they actually look a little bit more similar to what you look in the survival curve. So here you see that the surgery looks better than radiation, and it's more than like the real-time risk of dying from prostate cancer according to our data. And you can see that you can actually, much earlier than when they have recurrence, you can actually see the risk early. So this is patient with PSA value at this is patients after surgery, after radiation, and you see the risk of dying from prostate cancer. And if you're nadir, so you should basically nadir at undetectable. This is hormone therapy. This is actually so 75% of the patients in this areas will have 2 years of hormone treatment, basically. But you see that if you don't nadir, if you nadir to 0.1, you actually have a low risk of dying from prostate cancer. If you don't nadir, you immediately start to have a relatively high risk of dying from prostate cancer. It's even so that you can look at your PSA after 6 months, and it's actually a quite strong predictor. So patients, if you have a detectable PSA at 6 months, even after radiation, you have a high risk of dying from prostate, or you have relatively high risk of dying from prostate cancer. So we have earlier trigger points, potentially after radiation, where we can start to discuss if these patients would benefit from salvage therapy. So in this set of data then, prostate cancer-specific mortality favors radical prostatectomy over radiotherapy. Current definition of BCR favors radiotherapy over surgery. And I think that we need to look at this definition of biochemical recurrence and find something which is more easy to compare. And maybe also we should think about if we can intervene at an earlier state after radiation to try to see if we can salvage some of these patients before they actually die from prostate cancer. Thank you.